A very good morning. A very good morning to all of you, and good evening to those on the other side of the world. On behalf of Inetsys, I would like to welcome you all for today's session. Today, we have Professor Amit Mathur from Mayo Clinic, Arizona. Dr. Mathur is going to talk on management of cholangiocarcinoma. Is liver transplantation ready for prime time? Dr. Mathur is a distinguished transplant, hepatobiliary, and pancreas surgeon and is a professor of surgery at the Mayo Clinic, Arizona. He serves as the surgical director of the liver transplant program with expertise in liver, kidney, and pancreas transplantation, as well as surgeries for complex liver and biliary condition. Dr. Mathur is an internationally recognized leader in this field. His research focuses on improving access to transplantation, addressing health disparities, and enhancing outcomes in end organ failure and transplantation. Dr. Mathur is also deeply involved in transplant policy, finance, and regulatory issues. Please join us for this insightful session as Dr. Mathur shares his expertise on emerging role of liver transplantation in managing cholangiocarcinoma. So with that introduction, I would like to welcome Dr. Mathur, and Dr. Mathur, please share your screen, and look forward to your talk.
Good day and good evening to everyone. Thank you, Sanjay, for a wonderful introduction and an introduction to this hepatology club and video library. Today, I'm going to speak about an important topic, I think, in liver transplantation, which and particularly in the area of transplant oncology, which is the application of liver transplant for cholangiocarcinoma, which we all know to be a very heterogeneous disease process, but I think important one where transplant has a role in the care. I have only one disclosure, which I served at one point on the medical advisory board for AstraZeneca, which does have some medications that are used for systemic therapy in this disease process. But other than that, no other disclosures. Again, thank you, Sanjay, for the invitation today to talk about this topic. The objectives of this is really to discuss the current data on biliary tract cancer or cholangiocarcinoma and really to describe the role of liver transplantation. So I'll start today's discussion with a case. This is a case from our clinic. Actually, it was a case from my training time, but it was the case of a 64-year-old man who developed fatigue and painless jaundice in October 2009, had a laboratory evaluation, and there was a total bilirubin of 9.1. The initial workup included a right upper quadrant ultrasound, which demonstrated no significant gallbladder pathology, but there was intrahepatic ductal dilatation and extrahepatic bile duct measured 5 millimeters. The patient subsequently underwent a CT scan, and you can start to see that there is dilation of the biliary tree here along the left portal pedicle, as well as on the right side with right anterior duct and right posterior duct dilation. But in the central portion of where the biliary hilum we do not see this sort of darker area consistent with fluid on CT. Rather, we see more of what looks like liver parenchyma or soft tissue density at that level. And that continues as we come to the central portion of the biliary hilum, and then you see a complete loss of biliary, what I would call biliary signal in the middle of the biliary hilum. On subsequent MRCP, you can see that there is complete loss of signal in the central portion of the biliary hilum with dilation of the peripheral second and third order ducts. The patient underwent an ERC, and you can see that there is dilation of the right peripheral system, right anterior system, or right posterior system, right anterior system, and this is the left hepatic duct here. This is the gallbladder and cystic duct, but you can see at the first order biliary radicals, this is the right duct, and the left duct, there is a very narrow channel that's visible on this ERC, and that's magnified even more on this image as well. And you can see at the final ERC image, this is a very concerning biliary stricture. And so what this represented for this patient was a classic Klatskin's tumor. And when Klatskin originally described the Klatskin, the tumor for which he has been named after him, he described this in an American Journal of Medicine, a publication in 1965, where he described a series of 13 patients who had adenocarcinoma of the hepatic duct at the bifurcation. And the survival was quite poor, 71 months with a mean of 15 months. That was the longest survivor was the 71-month patient, but the mean was quite short. 9 patients of those 13 underwent surgical biliary drainage. There was a significant perioperative mortality rate, and the 6 survivors did survive a little bit longer than the overall survival. But there was really quite significant morbidity and mortality from this procedure at that time. And the primary causes of death were really related to failure of the hepatocellular compartment as well as biliary sepsis. So the conclusions from this was that many patients who have a laparotomy for biliary obstruction may frequently this tumor may be overlooked because that's not a typical area at that time that was explored. But death in the disease was really attributable to hepatocellular failure as well as hepatobiliary infection, because there was a failure to relieve that obstruction. And palliative surgery was recommended to provide internal drainage of the biliary tree. Now, what Dr. Klatskin at the time had described is what we know to be the larger sort of family of tumors that we term cholangiocarcinoma, which is divided into sort of intrahepatic cholangiocarcinoma, which makes up about 5 to 10% of the disease. More than half of the diagnosed cases of cholangiocarcinoma are perihilar, so those that occur above the cystic duct and into the first order biliary radicals, or even beyond, growing along the duct. And then, of course, there's distal cholangiocarcinoma, which is of the distal third of the common bile duct, growing into the intrapancreatic portion and down even toward the ampulla. And so for the purposes of the discussion today, we're really going to talk about extrahepatic perihilar as well as intrahepatic disease. Distal common bile duct cancers are typically treated with a Whipple procedure, and I think is a little bit beyond the scope of applicability of transplant in most cases. And so this is a disease that is of an older population. This is data from the SEER data set, just looking at data from the 1990s and early 2000s, which demonstrates clearly that the rate of disease and incidence is highest in older populations, at least in terms of the Western population. We may see it in earlier decades, depending on where the disease is diagnosed, because there are different risk factors for cholangiocarcinoma, and the density of those risk factors does vary based on the global location and home origin of the patient. Some of the risk factors for cholangiocarcinoma that we see typically in the Western world is really in the setting of primary sclerosing cholangitis, which has an 8 to 20% incidence. We see it in the setting of choledochal cysts, which also has about a 24% lifetime risk, which increases with time. In the setting of chronic hepatolithiasis or choledocholithiasis, as well as just in general in the setting of ulcerative colitis, even the absence of PSC. Much of the world sees cholangiocarcinoma in the setting of liver fluke disease, such as clonorchis, particularly in the Asian setting. But we see cholangiocarcinoma in the setting of chronic liver disease, particularly with viral hepatitis, but also in the setting of metabolic steatohepatitis or steatotic liver disease, particularly for intrahepatic tumors. The majority of patients, though, have no identified risk factors, and the epidemiologic associations are really lacking based on the current data. And so this shows this sort of variation in presenting signs and symptoms based on intrahepatic and perihilar disease, as well as distal disease. We typically see jaundice in tubular ductal obstruction, not so much in the intrahepatic setting unless it's massive degrees of tumor. And then weight loss is common, particularly in the obstructive diseases, and abdominal pain is probably more common in the intrahepatic portion. And you can see these are common risk factors that need to be evaluated in the history, physical examination, and early investigations. Diagnosis of extrahepatic cholangiocarcinoma, cross-sectional imaging is really critical. We consider it to be a necessity to do CT and MRI. MRI is probably the most sensitive for and identifying the specific cholangiocarcinoma. And when we have a patient with painless jaundice, we do routinely get an MRI and MRCP prior to doing any instrumentation of the bile duct when this is a potential cause. So that way we can obtain brushings and avoid percutaneous biopsy, which does obviate the ability to perform liver transplant. And I'll explain why that in a minute. Our cholangiocarcinoma protocol does include describing the tumor based on an MRI and MRCP imaging. And it's very, very critical to obtain that information, as it does have prognostic implications with and without transplant. Extrahepatic cholangiocarcinoma, when we begin, as we showed in this case, with cholangiography, we typically use ERCP, and then segmental decompression can often alleviate the jaundice, even if one duct is managed. We really try to avoid PTC to avoid perforation of the tumor plane. And so I always recommend that surgeons are involved early in the diagnosis, so that way there can be coordination of these types of therapies to leave all surgical options on the table. And so we prefer ERC. That's our standard at Mayo. We do obtain tumor markers, particularly in CA19-9 in ductal disease. But if there's a mass lesion present, there's often the potential for mixed tumors with HCC. And so AFP is also obtained. And we do, if there are mass lesions, we do evaluate those with LIRADS criteria in mind in cirrhotic patients. And then that helps guide the management as well. With regards to tumor markers, CA19-9 is probably the most important serum biomarker that we use in cholangiocarcinoma. And in a non-jaundiced patient, it does favor cholangiocarcinoma. However, you may see very high elevation of CA19-9 in the setting of biliary obstruction. And so we obtain this marker, and it's most important after biliary decompression is established. But when it is present in a decompressed biliary tree, and it's associated with a lesion on cholangiocarcinoma, a lot of times a very high CA19-9 predicts distant disease. And so patients in that situation are often unresectable. Key steps: do not obtain percutaneous biopsies. There is a very high rate of tumor seeding of the peritoneal cavity. And when there is peritoneal disease, it does obviate the ability to perform a surgical resection or transplant with a durable survival benefit. And so tumor seeding should be tried to be avoided. And negative biliary brushing does not mean that the patient does not have cancer. That is a very important pearl. And oftentimes a tissue diagnosis is very hard to establish. And it often takes multiple procedures to obtain it when all other clinical signs point to it. And so we have had many patients where it's taken multiple procedures to establish the diagnosis. And again, involve the surgical consultant early and obtain tumor markers when biliary decompression has been established. Very important. We do use endoscopic ultrasound in the setting. That is most useful for sampling regional lymph nodes, but it also oftentimes, depending on the person providing the EUS, can also image the radial margin of the tumor, and that gives us a suggestion of the extent of local spread of the disease as well. Staging is done by chest CT and PET, and it does have a poor sensitivity for lymph node metastases. It's only positive in about 12% of patients with lymph node metastases, but it has a good sensitivity for ruling out distal metastases outside of the regional basin. As I mentioned, distal cholangiocarcinoma typically managed with pancreatic duodenectomy, and the prognosis does vary depending on the outcomes of that procedure do vary based on the pathology, and bile duct pathology does often mirror pancreatic ductal carcinoma. It's very important to define the extent of disease in extrahepatic cholangiocarcinoma, and this was the patient we initially described, and we try to provide that classification both in terms of a bismuth class, looking at the extensive disease along the biliary duct. Of course, class 1 tumors are just limited to the common hepatic duct, with class 2 and class 3 with varying involvement of the right and left hepatic ducts. Typically class 4 class 4 bismuth tumors where there's growth along into the second order radicals is considered surgically unresectable disease, but this is an area where liver transplant is feasible. And in addition to evaluating the extent of disease along the duct, involvement of vascular structures is also very important to assess on those cross-sectional images. In looking at series of surgical outcomes following resection for cholangiocarcinoma, it is, and these are dating back, almost 30, 40 years now. And you can see from all of these sort of global studies, which is very important, is that there's high variability in the ability to establish resectability, to obtain an R0 resection, the variability in performing a concurrent hepatic resection along with the ductal resection. And there's very high morbidity and mortality with these procedures, up to 20% with surgical resection alone. And 5-year survival at best is 45% in this disease process. And that mortality, long-term mortality, is really driven by the presence of lymph node disease as well as the presence of residual tumor at the end of the resection. And you can see R1 patients really get very little benefit from the resection. And there is universal mortality by 36 months based on Alan Hemming's study back in his resection series in 2005. And then in lymph node positive disease, there is very little excellence in long-term survival compared to the lymph node negative patients, where there seems to be the best durable results with surgical resection. So what did we do in this patient that we initially described? The CA19-9 was 184, so relatively high. The jaundice ended up being needed to be relieved with PTC without crossing the tumor plane. We did identify that there was proper hepatic arterial involvement with the tumor, but there was no evidence of metastatic disease on the cross-sectional and PET scan imaging. So at Mayo Clinic, we have a very specific approach to perihilar cholangiocarcinoma. And since around 1994, we've been offering liver transplant for patients with extrahepatic cholangiocarcinoma. Our typical approach is really quite simple. So if it appears surgically resectable based on a multidisciplinary review, then we typically recommend resection with excision of the extrahepatic biliary duct, a regional lymphadenectomy with a concomitant liver resection, depending on the degree of involvement of the right or left duct, and with plus or minus resection of the caudate lobe. Caudate lobe resection is very common in this disease process. However, if it appears unresectable, if there's vascular involvement, or if the disease arises in the setting of concomitant liver disease such as PSC, then we do not recommend resection. It carries a much higher risk of morbidity and mortality and failure of clearance of the disease. And so we recommend a neoadjuvant chemoradiation protocol followed by maintenance oral chemotherapy and then liver transplant down the line. And so our approach with this neoadjuvant therapy approach, it has evolved over time, but the classic approach that we have recommended in our protocol and still lives in our protocols at three of our destination medical centers is that we perform neoadjuvant chemoradiation and at our center we use SBRT to provide this radiation with a short course of radiation therapy to the biliary hilum with a chemosensitizer. Following that, patients are placed on oral capecitabine, and then they undergo, after that radiation therapy, a staging procedure to assess the regional lymph nodes. We have found that the best detection of lymph nodes is through surgical resection of the biliary draining lymph nodes in the porta hepatis. And as opposed to using EUS guided biopsy, there is a much higher rate of false negatives with EUS related to sampling. So we get the most complete results with a surgical resection of the tree, of the nodes, and that we use that prior to liver transplant. If the nodes are negative, then we proceed with listing for liver transplant or with the live donor liver transplant, depending on the local context. We do see about 20% rate of lymph node positive disease, which does rule out patients for transplant, and I'll show you the reasons why that is. It's important to consider that once you commit to the radiation to the biliary hilum, resection becomes unsafe. After high-dose neoadjuvant chemoradiation, it is very difficult to separate the biliary tree from the vascular structures. And so even for the remnant that is intended in a resection, the vasculature can be compromised through the neoadjuvant approach. So once we commit to the radiation, we're either going to transplant or palliation. And that's a very important thing that we describe to our patients, that crossover is very difficult. And so in general, our rule of thumb is that if we are in doubt for an R0 resection prior to this treatment, we proceed with the transplant protocol. If we suspect nodal disease, then we aim for resection because the transplant outcomes are worse with node positive disease. Eligibility for our liver transplant protocol, there has to be a malignant appearing stricture and at least one of the following: malignant cytology or histology obtained by biliary brushing, a CA19-9 that is elevated. The polysomy on FISH is important to see. If a malignant brushing is not feasible to see, and a mass on cross-sectional imaging is also eligible. So one of the following really needs to be there, along with a malignant appearing stricture. The cancer has to be located above the cystic duct in most cases, and it has to be considered unresectable disease. If that is in the setting of de novo cholangiocarcinoma, very important. So unresectable disease typically means if there's vascular involvement, or if the cancer is arising in the setting of pre-existing chronic liver disease such as PSC. Exclusion criteria for our liver transplant protocol, very important, is if there's been a prior attempted resection with violation of the tumor plane, or if there's been a transperitoneal biopsy, if there's a presence of a radial margin tumor greater than 3 centimeters, and then if there is intrahepatic or extrahepatic metastases in biliary cancer, as well as the presence of documented nodal involvement. Those exclude patients from proceeding with transplant because the outcomes are poor in this setting. Now, this protocol was originally designed in the 1990s, and we recognize that there is evolution in the treatment of advanced biliary tree cancers, and like anything, all protocols are made to evolve. In our initial evaluation of outcomes, looking at 25 years of patients in the Mayo Rochester system, there were 349 patients who went on to be evaluated and undergo chemo and radiation. 45 patients of those had progression of disease or died prior to the staging procedure. 6 were transplanted elsewhere outside of the system, and there were 21 at the time, at the cut point time, that were still awaiting stages. 277 patients underwent staging. 20% of patients had lymph node positive disease. If those patients had lymph node positive disease, they were taken out of the protocol and underwent palliation. However, those who had lymph node negative disease underwent waiting for liver transplant, either with, again, deceased donor or living donor transplant. At the time, 2 patients awaited transplant, 3 were transplanted elsewhere, 5 progressed while waiting at this step. But 134 patients underwent deceased donor transplant. There were 78 living donors and 1 domino donor from a patient who donated an amyloid liver to a cancer patient in the setting of their own transplant. And so you can see that in this, the intention to treat from the start of therapy, the patients with PSC really had the best 10-year outcomes. So 52% of patients with PSC had survival at 10 years. And de novo patients, the outcomes were still low, as you would expect, 32%. And this is in the intention to treat arm. So this is all comers that came to the protocol. And this is based on a cut point in August 2018. But if you look at the patients who actually underwent transplantation, the PSC patients did tend to do better than the de novo cholangiocarcinoma patients. But you can see that the outcomes really, compared to the intention to treat, including patients that did not go any resection or transplant, the outcomes with PSC patients, 70% 10-year survival. And this is based on patients that were treated from 93 to 2018. And then even in the de novo patients, a 50% 10-year survival. So this is really excellent outcomes for this disease process. And I would argue even potentially better than surgical resection. And this is related to full clearance of the disease. There is an Arzua resection with transplant every time. So our original patient enrolled in our protocol in January 2010, underwent liver transplant in April 2010, and the final pathology from that explant pathology from the transplant hepatectomy, she demonstrated no residual tumor with extensive treatment effect from the neoadjuvant therapy. So that sort of summarizes our approach to liver transplant with extrahepatic cholangiocarcinoma. But I'm going to talk a little bit more about intrahepatic cholangiocarcinoma now. And intrahepatic cholangiocarcinoma, I think, is a bit more insidious in terms of its presentation. It can often present as a large mass lesion because it is clinically silent frequently prior to a new clinical sign or symptom developing. It is often discovered even as an incidental finding, either in patients who have chronic liver disease who undergo screening for cancer, or it comes up in an occult abdominal pain evaluation. And so the CT and MRI are really critical as there is initial rim and peripheral arterial enhancement followed by centripetal enhancement in the delayed phases. Those are, but there's also hypodense disease on CT and a very typical a distinct pattern of enhancement from hepatocellular cancer on MRI. And so in chronic liver disease, these are the patients on MRI that do not, the mass lesion that may look atypical, but do not meet LIRAD's criteria for HCC. We do have a high suspicion for intrahepatic cholangiocarcinoma in that setting. And in that setting, biopsy is essential to differentiate it from HCC. These patients do have typically elevated CA19-9. If Lewis antigen is negative, the CA19-9 is normal, and that, important to know, is a frequent in 7% of the Western population. So an important thing to consider. When the diagnosis is established, the treatment, the surgical mainstay of treatment, or the mainstay of treatment is surgical resection, if surgical resection is possible. Predictors of outcome include the size of tumors, whether or not there are multifocal disease, or if there's nodal metastases. Those, stage 3 tumors, meaning those that have nodal disease based on TNM staging, do have a worse prognosis. But in current protocols, there's been several studies from across the world where they've evaluated the role of transplant. Perhaps the most data we have is from transplanting patients, or sort of identifying the outcomes of patients who were transplanted with mixed tumors, or there was intrahepatic cholangiocarcinoma identified in small lesions on explant pathology of patients who underwent transplant, and the diagnosis was unknown. When that was found, there is actually really excellent outcomes from the liver transplant. 73% 5-year survival, which mirrors what we see in other causes of chronic liver disease, and that's back in 2014. And in follow-up studies for those less than 2 centimeter type lesions, there was a 5-year survival of a greater number of patients that was around the same, 65%. When patients present with a mass lesion in the chronic liver disease or cirrhosis setting, they're often being in the setting of where we're trying to identify hepatocellular cancer. And so local regional therapy is often discussed, I think in the Western context, almost universally, to provide some local regional control of a growing tumor, regardless of the origin. And so these are evolving strategies for the treatment of intrahepatic cholangiocarcinoma. At my own center, I would say we use this very liberally in even suspected intrahepatic cholangiocarcinoma in the setting of chronic liver disease after obtaining a biopsy. And so to provide some degree of local control, and I'll describe this in more detail. So when you see patients, and this is based on a Nature review in 2018, when intrahepatic cholangiocarcinoma is discovered, if they're a candidate for resection, and there are multiple things that contribute to the candidacy for resection, surgery is the mainstay. If they're not a candidate for resection, then local regional therapy needs to be considered. There are a multitude of options. And if there is a failure of therapy, then alternative systemic therapy should be considered. Now, this is based on 2018 data. Things have changed, particularly with regard to the advent of immunotherapy and targeted therapies being used in cholangiocarcinoma. And I'll talk a little bit about that and how we apply it in the transplant context. Now, there's been an intrepid group of surgeons in a collaboration between Houston Methodist Hospital and MD Anderson Cancer Center, and that has been in the use of liver transplant for locally advanced intrahepatic cholangiocarcinoma with use of neoadjuvant therapy. Back in 2018, they presented a prospective case series in Lancet Oncology, and it was just a very small series, single center prospective analysis of 6 patients with large intrahepatic cholangiocarcinoma. So the average total tumor burden was 10 centimeters of tumor diameter cumulatively, and a median of 4 lesions. And these patients were treated with neoadjuvant chemotherapy at that point in time. This was gemcitabine and cisplatin was the first-line therapy. As this evolved, FOLFOX became the second-line neoadjuvant therapy. But that was what we knew at that time, and that was what was applied at that time. And so gemcitabine cisplatin was the first therapy. And you can see that there was, for those patients who were transplanted, really had an excellent 5-year survival of more than 80%. Recurrence-free survival was less good. Most of the recurrences happened within 12 months, but you can see that for those after those recurrences at the 50% progression-free survival at 12 months, those patients still had treatment options and were able to live longer. And so this really was an intriguing early experience. I think for in the Western context, still some skepticism, but we thought that was a promising thing. And subsequently, this team published their survival following liver transplant for large intrahepatic cholangiocarcinoma, and really able to really demonstrate some important findings in the American Journal of Transplantation back approximately 2 years ago. What they saw was that 65 patients were evaluated for transplant. And of those, 37 went on to be listed for transplant. Many were declined for listing related to the presence of and detection of extrahepatic disease, or they were found to have surgically resectable disease, or there were other transplant criteria that were not met, for example, comorbid cardiac conditions, et cetera. Those that underwent and were listed for transplant underwent neoadjuvant chemotherapy. 5 of those patients actually went on to undergo surgical resection, so they became resectable through this approach. That was 5 patients of the 37, and then 18 patients underwent liver transplant. 14 patients, importantly, did not undergo transplant after listing, and that was due to progression of disease, either death from the disease, an aborted transplant, or remain. And at the time of this evaluation, 7 remained waiting. And so it's really important to realize that we're at not even with the group that has probably published and looked at this the most. There's not a universal applicability of transplant in this disease process. There is clear evidence of the need for observation of the disease over time on neoadjuvant therapy. And so what this was where liver transplant is really being used is in unresectable disease with upfront systemic therapy and disease stability for at least 6 months, importantly with no evidence of progression or metastatic disease. 18 patients underwent transplant, as I mentioned in this, and their outcomes were really quite excellent. 100% 1-year survival, 71% 3-year survival, and 57% 5-year survival of these 18 patients that underwent liver transplant. You can see this is the survival curve of what I just described. Those who were listed but not transplanted, the 24-month, there was approximately 40% survival at that time point for those who were not transplanted. This is progression-free survival, and you can see what we see is that at 36 months there still is a relatively high rate of a recurrence of disease, but what we did see was that there are a good number of patients in this series that did well with bulky disease, median tumor number of 2 lesions, median tumor diameter, cumulative tumor diameter, it was 10 centimeters. And there was a high frequency of mutations in these patients. The 26 of the 32 patients in the protocol who were listed did undergo next generation tumor sequencing, and 16 of 18 underwent this tumor sequencing in the liver transplant arm. These were obtained by either pre-procurement or biopsies prior to treatment, but through liquid biopsies or explant pathology biopsies. And you can see there's a high frequency of actionable tumors here based on their mutations. And so that was one thing that became promising. So what this really represented was that with a prospective protocol for locally advanced intrahepatic cholangio, using neoadjuvant therapy, time of observation of tumor biology and liver transplant. If you compare what we're seeing with the 5-year outcome, this is very similar to what we see in liver transplant for other oncologic indications, such as colorectal mets, which we are seeing and has been discussed in this lecture series, but also in data from Norway as well as now North America and Paris. So we see that there is similar outcomes with this approach that this group has described. So this is really intriguing data, and I think a lot of programs, including my own, are starting to think about how we can apply this in our own patient populations to provide transplant care to a greater population of patients with intrahepatic cholangiocarcinoma beyond what we do with our Hyler protocol. What we have found and what we have an active protocol for is for patients who have small intrahepatic cholangiocarcinoma. This was based on Spanish data from Gonzalez-Saposochen on mixed tumors. So we do offer a approach that's very similar to what we do in HCC. We provide local regional therapy. We do require stable disease for 6 months to demonstrate favorable tumor biology. This is after the biologic or the pathologic diagnosis is established. And we do think when we have stable disease for 6 months, that does demonstrate favorable tumor biology. But based on the data we saw from the Houston Methodist and MD Anderson groups, there is a potential role for liver transplant for larger, bulkier disease. But again, neoadjuvant therapy and observation is clearly critical to select patients better. There is a clear need for further prospective multi-center data to prove the benefit and to help identify what patients should be selected, particularly in the setting where we know that there is a high, in intrahepatic cholangio in particular, high rates of mutations and potentially the role for targeted therapies as well as cytotoxic chemotherapy and immunotherapy. And so those may help select upfront therapies and help us select who should have a transplant or not. And so what we are seeing in that space, of course, has been the emergence of immunotherapy through the TOPAZ-1 trial, multi-center international trial, where they compared 341 patients who underwent a cytotoxic chemotherapy with gemcitabine and cisplatin with durvalumab, compared to those who underwent a similar chemotherapy regimen with placebo. And that's a large trial, 685 patients total. There was longer progression-free survival in the durva arm, 7.2 months versus 5.7 months. Again, this is in advanced biliary tract cancer. There was better overall survival, a 20% relative risk reduction in mortality overall, and a 25% relative risk reduction in progression-free survival, better objective response rates in the patients who had the immunotherapy and chemotherapy together. And their longer follow-up from this initial phase 2 or phase 3 study has demonstrated that it supported this large difference in survival that we saw in the initial study, and there's no new safety concerns identified in the follow-up study. So what that demonstrates to the world with biliary tract cancer is that the addition of durvalumab to GemCis chemotherapy represented a new standard of care in advanced biliary tract cancer. And we're seeing durvalumab being applied essentially very broadly in practice to biliary tract cancer now that we're seeing that type of benefit. And so when we're thinking about that in the transplant context, we often get patients referred for transplant who have already began their diagnostic journey at other centers, and a lot of times come to us already on systemic therapy with either GemCis and immunotherapy durvalumab and second-line cytotoxic therapies. And so how to get those patients into our transplant protocol is really what we've been trying to tackle. And what we have come across is that if they have started this type of therapy, we do use it as an additional selection tool. And so when patients have started that, if they do not have progression of disease on the therapy, we then stop the systemic therapy and immunotherapy and move into our neoadjuvant radiation and chemo protocol if they would otherwise have met it. And then they go through the Hyler protocol as any other patient would that didn't have the systemic therapy up front. But when patients are on the systemic therapy up front, it does provide us with potential more time to assess tumor biology. And I think that's very important with ensuring the appropriate outcome and best outcome with the resource of liver transplant, no matter what context you're in, either with living donor grafts or deceased donor grafts. That's a valuable resource we need to preserve. For our patients with intrahepatic cholangiocarcinoma, I think we're seeing more of the chemotherapy, systemic therapy regimens being used in this disease process. because those patients do not have obstruction. There is less sometimes urgency to refer in a timely way to transplant centers. And so we do think it's acceptable for patients to be on systemic therapy, including durvalumab. A lot of these patients are being biopsied and sequenced prior to referral, and with liquid biopsy or with tumor tissue. And that has been an important sort of change that we've seen in this disease process. It is critical for, I think, those of us who are in the liver transplant field, hepatologists and liver transplant surgeons, to involve our medical oncology colleagues in collaboration to help determine what's going to be the best treatment strategy for patients with intrahepatic tumors based on the sequencing. Local regional therapy in our context is still required for our small intrahepatic cholangiocarcinoma. Observation is still required. So the role of immunotherapy and systemic therapies is evolving. We think it's acceptable right now as long as patients do have this sort of progression-free 6-month period to get listed for transplant and that they don't progress while listed. But more data is still required. But I think the future is really interesting because I think the future state really is going to involve a multidisciplinary approach, surgeons, radiologists, the medical oncologists, and hepatologists together deciding on using the synergies of all of these approaches. So systemic therapies, meaning cytotoxic chemotherapy, immunotherapy, targeted therapies based on tumor sequencing, as well as local regional therapy prior to transplant. And that will allow us, I think, in the future to really optimally select the patients who should undergo transplant for intrahepatic cholangiocarcinoma, as there is still emerging data on where we should be with those with locally advanced disease. And I think this is going to be really critical. And, as programs across the world start to apply transplant in this context. So some final thoughts on cholangiocarcinoma. Sanjay had asked me when we were planning this lecture, is this ready for prime time? Well, I think in hilar cholangiocarcinoma, prime time is really now. In small intrahepatic cholangiocarcinomas, if there is a 6-month observation after local regional therapy and transplant would otherwise be needed for management of cirrhosis, liver transplant is safe and successful, mirroring what we see in other oncologic indications. I think the area where are we ready for prime time question is most applicable in multifocal and large unresectable disease. And I would say right now we need more data. So there needs to be multi-center prospective studies. And I think global studies are going to be the most important to really understand this disease. And I hope that we will see that evolve in centers and parts of the world where there is live donor liver transplant or more available deceased donor transplant, quite simply because that we get the most data in transplant oncology from those localities, as we will be able to better assess the whether or not there's progression, because there's some more controlled time to transplant as well while waiting, but we'll also be able to see in more rapid fashion what happens in the post-transplant setting with regard to recurrence. So are we ready for prime time? In hilar disease, we definitely are ready for prime time. With regard to transplant in small intrahepatic disease, I think it's applicable as long as the patient has other indications for transplant. But again, multifocal large unresectable disease, we need more data. However, if the patient is resectable, in most contexts, transplant should be avoided. Resection should continue to be the mainstay, just based on the prevalence of the disease and incidence of disease across the world. So I think that's a really important point. Again, I'd like to thank everyone for joining today, and who will see this potentially in a delayed fashion in the video series. I would encourage you all to visit us at Mayo Clinic in Arizona. We have I think one of the most beautiful campuses for a transplant and hepatobiliary center, hepatobiliary oncology center that you can really have. And I would be happy to welcome you here as a visitor and to participate in our academic collaborations here. Thank you.